I'm just feeling sick है आज गीत बजाउँदिन म बस्छु आज काम छैन है I'm positive है I'm corona positive covid positive के गर्ने भन्दाखेरि जाने पढेर बस्दिने हैन एटमी especially now. Otherwise, गर्नुपर्छ साथीहरू होइन जस्तो कोभिड not just but it's COVID but गर्नुपर्छ. Don't take it granted but yeah, don't worry.
Welcome to Neuroscience. We're going to begin our neuroscience review with a clinical evaluation of the components of the central nervous system first and how they develop. First off, on the next page, we can subdivide the nervous system into its two basic components. The peripheral...
Wait.
nervous system contains the spinal and the cranial nerves and the neuronal processes that make them up. The central nervous system basically consists of the brain and the spinal cord, elements that are formed, as we'll see, from the neural tube. Taking it together, we can say that the entire nervous system is either a derivative of the neural tube, if it's the CNS, or neurons that make up fibers in nerves are formed mainly, but not exclusively, from neural crest cells. For example, as we list at the bottom of the page, skeletal motor neurons and axons of preganglionic autonomic neurons are derived from the neural tube and grow out from it, meaning their cell bodies are still contained within it. Neural crest cell derivative neurons that will be found in nerves will be postganglionic autonomic neurons and primary sensory neurons. So simply put, neurons that are found in nerves are a combination of neural tube cells and neural crest cells. Next point that we need to make is, what are the two glial cells that form myelin for either axons in the peripheral nervous system in nerves, or make myelin for a tract fasciculi lemniscus or funiculi, bundles of axons inside the CNS? And the difference is significant. Schwann cells are neural crest cell derived glial cells that make myelin for any axon in the peripheral nervous system, regardless of its embryonic origin. Oligodendrocytes make all myelin for any axon contained within the CNS, any tracts or fasciculi, including, as we will see, all of the myelinated axons of the optic nerve. The other difference is Schwann cells can only myelinate a single segment of a single axon, whereas oligodendrocytes can myelinate many segments.
Kanan thale. Oi तुम्हाला हिराला देता अच्छा oi तुम्हाला हिराला देना तुम्हाला हिराला दे आणि अंदर केटा भेरौ न तुम्हाला हिराला दे रे हां हाले केटा लगाउन एउटा oi त्यो केटा भेरौ न तेरो केटा भेर्ने रेले Mal deh rala, naik mal deh rala. Oil din juga, ira bayar dah ira. पाखे देखायो पाखे नाच 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 भने नाच नाच भने नाच के नाच नाच भने सुन्नुहोस् जा जा छैन जा छैन के जा जा बाई जा म बाई पढ्छु
Segments of many adjacent segments of individual axons inside the CNS. Let's now briefly look at disorders of demyelination, and they include a central demyelinating disease, which is multiple sclerosis. This affects myelinated axons inside the CNS exclusively and also includes the myelinated axons frequently of the optic nerve and the myelinated axons of the medial longitudinal fasciculus. These patients are likely to present with altered vision, internuclear ophthalmoplegia when you affect the axons of the MLF, and they present with motor and sensory deficits that tend to come and go. This is a chronic inflammation of axons presenting usually with increased oligoclonal banding in the CSF, and it's usually treated with high-dose steroids. Other demyelinating diseases include metachromatic leukodystrophy. This is a lysosomal storage disease where there is a deficiency of the aryl sulfatase A enzyme, and it affects myelin in both the central and the peripheral nervous system. Patients that develop progressive multifocal leukoencephalopathy, or PML, are immunocompromised patients, often characteristic of aged patients, and these present with demyelination involving limb weakness and cortical problems. Finally, when there is a progressive bilateral demyelination, typically in the rostral and basal pons, patients might present with what is known as the locked-in syndrome. This is a patient that has bilateral demyelination of both the corticospinal and the corticobulbar tracts, resulting in spastic quadriplegia, and also a total loss of all cranial nerve function except for cranial nerves 3 and 4. Lastly, Guillain-Barré syndrome is a classic demyelinating disease of the peripheral nervous system only. It typically presents in most patients that have had a recent history of a respiratory or GI illness. Motor signs and symptoms are always present, usually bilaterally in the limbs. These patients also may present with autonomic dysfunction, some cranial nerve involvement, particularly medullary cranial nerves. Sensory loss is highly variable. The sensory loss can be mild or severe and present with altered sensation of touch, vibration, and pressure, including altered sensation to pain. And classically, because of the motor neuron involvement, these patients have suppressed or absent muscle stretch reflexes. The next topic, sensory loss is quadriplegia syndrome, and also a total loss of all cranial nerve function except for cranial nerves 3 and 4. Lastly, Guillain-Barré syndrome is a classic demyelinating disease of the peripheral nervous system only. It typically presents in most patients that have had a recent history of a respiratory or GI illness. Motor signs and symptoms are always present, usually bilaterally in the limbs. These patients also may present with autonomic dysfunction, some cranial nerve involvement, particularly medullary cranial nerves. Sensory loss is highly variable. The sensory loss can be mild or severe and present with altered sensation of touch, vibration, and pressure, including altered sensation to pain. And classically, because of the motor neuron involvement, these patients have suppressed or absent muscle stretch reflexes. The next topic we want to cover is the process of neurulation. And the events involved in neurulation are summarized on this slide. Note first off that neurulation begins in week 3, immediately after gastrulation. The time frame is important because even though all nervous system components are derived from a derivative of ectoderm, one of the 3 germ layers that's established at gastrulation, the notochord must be present in the developing mesoderm so it can induce the overlying ectoderm, as we will see, to form the central and the peripheral nervous system. The 3 stages of neurulation are the following. The notochord induces the overlying ectoderm initially to form a thickened portion of neural ectoderm called the neural plate. Secondly, the neural plate undergoes a subsequent invagination in the future dorsal midline and forms a pair of neural folds. Later on, those neural folds will meet and fuse in the dorsal midline to form a completely hollow neural tube. So the 3 stages of neurulation basically are the formation of a neural plate, followed by the formation of a neural groove and neural folds, finally seeing the formation of a hollow neural tube. In addition, at the same time as neural tube formation, neural crest cells also develop from the overlying neuroectoderm, but they develop outside the developing neural tube, as we'll see, near the margins of each of the neural folds. Next point down at the bottom of the page is that even at its early stages of formation, the neural tube acquires a polarity, in that the dorsal half of the neural tube will develop into what's called the alar plate. In the alar plate, we will see the development of sensory neurons. The ventral half of the neural tube will give rise to a basal plate, and in the basal plate, we will see the development of motor neurons inside the central nervous system. And the plates, as we see here, are going to be separated by an embryonic sulcus limitans. Note, as we pointed out earlier, that neural crest cells mainly will form neuronal processes and neuronal cell bodies that are associated with nerves. But being specific at the bottom of the page, they will form all primary sensory neurons in cranial and spinal nerves, and they will also give rise to all of the postganglionic autonomic neurons that are also found in cranial and spinal nerves. And finally, as we know, the peripheral nervous system, we said, consists entirely of nerves, and we're just providing the numbering scheme. There are going to be 12 pairs of cranial nerves and 31 pairs of spinal nerves, each with a combination of neural tube and neural crest cell derived neurons. Next, on this page, we're going to look at a series of diagrams that illustrate the process of neurulation. And the picture on the left side of the page illustrates a view of the future dorsal midline of the developing embryo at about day 18. And we're looking down at basically what is a view of the overlying ectoderm. And what we're seeing superimposed on the diagram is the beginning of the appearance of the notochordal process that develops in the underlying mesoderm. And in the cross-section indicated by letter A over on the right, we see a trilaminar embryo. And what you're seeing here is the position of the notochord in the future dorsal midline and the fact that it has now released inductive factors that have caused the overlying ectoderm to thicken first and form a neural plate out of neuroectoderm. And what you're seeing at letter A is the secondary formation of a shallow neural groove lined on either side by a pair of neural folds. In B, we can see that the neural groove gets progressively deeper and the neural folds elongate, and we also see developing at the lateral lips of each neural fold the series of where neural crest cells will also develop. Finally, in the next picture, we can see at letter C that the lips of each neural fold have migrated toward the midline and have fused to transform a shallow neural groove into a completely enclosed hollow neural tube. And once neural tube formation is complete, the neural tube sinks down and becomes completely surrounded by mesoderm, and then the site where neurulation took place is overgrown by surface ectoderm, so there's no evidence in postnatal life that neurulation was a surface ectoderm event. Secondly, you can see that the neural crest cells developed at the same time have migrated toward the mid trilaminar embryo. What you're seeing here is the position of the notochord in the future dorsal midline and the fact that it has now released inductive factors that the secondary formation of a shallow elongate. Finally, in the next picture, we can see at letter C that the lips of each neural fold have migrated toward the midline and have fused to transform a shallow neural groove into a completely enclosed hollow neural tube. And once neural tube formation is complete, the neural tube sinks down and becomes completely surrounded by mesoderm, and then the site where neurulation took place is overgrown by surface ectoderm, so there's no evidence in postnatal life that neurulation was a surface ectoderm event. Secondly, you can see that the neural crest cells develop at the same time, but develop in a position that sees their location outside the developing neural tube. And down in figure D, you can see their classic dorsolateral position where they form initially adjacent to the neural tube. And this position outside the neural tube will give neural crest cells the ability not only to form or overall neural tube, where we see that vesicles said that the mid sub epiphyta. We indicated that spine. Finally, not related obviously to brainstem lesions, but it's worthy to note that there are several chemically significant populations of neurons that are found in various parts of the brainstem. We call these reticular nuclei in a way because the reticular formation kind of forms the core of the brainstem. Parts of it are involved in sleep-wake cycles and regulating cardiovascular function and gastrointestinal function and so on. But the point that we make on here is just to remember the neurochemicals that are produced by these various nuclei and where they are found. The nuclei of the raphe are situated very close to the midline. They are a discontinuous column of cells that extend throughout much of the brainstem. Those neurons basically produce, synthesize, and release serotonin that's widely distributed throughout the CNS. An adjacent nucleus that's mainly associated with the upper pons and extends into the midbrain is the locus ceruleus, the blue spot. And the locus ceruleus contains neurons that synthesize and release norepinephrine, and again, whose projections project virtually throughout the CNS. And we know that central nervous system norepinephrine is playing a role in sleep-wake cycles and maintenance of levels of arousal. Finally, the periaqueductal gray, which as the name implies surrounds the aqueduct in the midbrain, contains opioid receptors that are sensitive to collaterals or innervated by collaterals of the spinal thalamic tract, and their job is to provide an internal mechanism, an intrinsic mechanism, to help suppress a painful stimulus when they're activated by an incoming pain stimulus generated by the spinal thalamic tract. The next section that we're going to cover in some detail is a very important one in terms of clinical neurology, and this is in Chapter 5, the brainstem. Certainly, the brainstem is going to be the home of most of the cranial nerves, so this is where we'll deal with their detailed clinical anatomy. Fundamentally, the brainstem is divisible into three parts. They are the midbrain, the pons, and overlying the pons will be the cerebellum, which we'll talk about later, and the medulla. The midbrain basically begins just below the diencephalon. It's its own brain vesicle. The pons is in the middle, as we said, is overlain by the cerebellum. The medulla is the most caudal portion of the brainstem, and it's continuous with the spinal cord. As we said, the brainstem is important for a variety of reasons, the major one of which is it is the home of the nuclei, the sites of termination or origin of the fibers of 9 out of the 12 cranial nerves. The only cranial nerves that are not brainstem cranial nerves will be cranial nerves 1, the olfactory, 2, the optic nerve, and cranial nerve 11, the accessory, which is really a misplaced cervical spinal nerve because its motor fibers arise from cervical spinal cord. Then here is the organization, which we'll then look at a diagram to this, that will typically involve a Next, let's look at the details of blood supply to an individual hemisphere. We've already seen that the medial and lateral aspect of the hemisphere have a different blood supply. Now let's look at the origins of the cerebral vasculature. Note that the blood supply to the entire brain comes from 2 pairs of arteries. It comes from a pair of internal carotid arteries that form by its branches the anterior circulation, and it's formed by the branching pattern of a pair of vertebral arteries whose branches will form the posterior circulation. Note that the anterior and posterior circulations are linked from front to back as well as across the midline and form what is known as the circle of Willis. So let's detail its branches. First off, note that, as we discussed earlier, the posterior circulation's job mainly is to supply the brainstem, the cerebellum, but also the posterior and inferior aspect of each hemisphere by giving rise to a pair of posterior cerebral arteries. So the posterior circulation, vertebrals unite to form a basilar. The basilar at midbrain levels will divide into a pair of posterior cerebral arteries. Those posterior cerebrals are supplying the medial aspect, mainly the occipital lobe, and the inferior aspect of each hemisphere. The 2 major branches that arise from the anterior circulation are a middle cerebral artery and an anterior cerebral artery. The middle cerebral artery, as you can see, is really an extension of an internal carotid, and it sweeps out to supply most of the lateral aspect of a corresponding hemisphere, whereas the anterior cerebral artery branches acutely from the internal carotid and dives into the inner hemispheric sulcus to provide much of the blood supply to the medial aspect of a corresponding hemisphere. So what links the circle of Willis together are 3 communicating arteries. There's a very small anterior communicating artery that joins the 2 anterior cerebrals together by crossing the midline. And there are a pair of posterior communicating arteries that actually link the 2 circulations together. They provide a link between each internal carotid and each posterior cerebral on a corresponding side, but they're really the weak links in the circulation. Potentially, they provide a collateral blood supply from front to back, but typically in a patient that has had an arteriogram, the arteriogram commonly will only light up either the branches of the anterior circulation or branches of the posterior circulation, and not both. The last point we want to make before we look at the details of this is, where are the most common sites where we see the development of berry aneurysms? And the answer is, by a large margin, the most common site of development of such aneurysms is in branches of the anterior circulation, much more than the posterior. The most common site, approximately 25% of the aneurysms that develop, occurs, as we indicate in the box on this figure, right at the branch point between an anterior cerebral and an anterior communicating artery on a corresponding side. Now, let's look at an arteriogram of the carotid circulation. This is an AP view, so this is viewed as if you were looking at the patient. And what we've lit up with a negative contrast and dye injection is the branching pattern of the left internal carotid artery. And as we indicated, we know that the left internal carotid artery is giving rise to a left middle cerebral, whose branches you can see branching extensively on the lateral aspect of the hemisphere, and an anterior cerebral artery that dives, as we said, has a relatively straightforward course supplying the medial aspect of a corresponding hemisphere by going through the interhemispheric sulcus. So one of the issues that can come up is the exam questions can show you an arteriogram and ask questions such as I've indicated on the slide as to what part of the motor or the sensory homunculus might be supplied by an unlabeled anterior or middle cerebral artery. And as we've already discussed, we know that the middle cerebral artery is going to serve or supply the upper half of the corresponding motor in the sensory homunculus, head, neck, upper limb, and part of the trunk, whereas the anterior cerebral artery will supply the lower half of a corresponding homunculus, including pelvic structures, muscles and skin, and the corresponding lower limb. And then the other point that can be made about this is, remember that we can develop an aneurysm of the internal carotid artery just before it branches into the anterior and the middle cerebral. And as we've alluded to in this anatomy review, obviously the presentation might differ somewhat dramatically if that aneurysm of the internal carotid expands in the medial direction or in the lateral direction. And here's the difference. When I have a medial expanding internal carotid aneurysm, that is likely to compress the temporal optic nerve axons on the outside of an optic nerve on a corresponding side, this being the left side, and this patient would develop a left nasal hemianopsia. But if the internal carotid aneurysm expands laterally, it's likely to involve structures in the cavernous sinus. And the nerve that is traversing just lateral to the internal carotid artery that's likely to be affected initially by the aneurysm will be the abducens nerve. So a patient is likely to develop an internal or a medial strabismus as a result. Next, aneurysm will be in the cavernous sinus. And the nerve that is traversing just lateral to the internal carotid artery that's likely to be affected initially by the aneurysm will be the abducens nerve. So a patient is likely to develop an internal or a medial strabismus as a result. Next, let's look more specifically at the vascular territories of the anterior, middle, and posterior cerebral arteries. We've already alluded to this, but now we're looking at a couple of views of each hemisphere, particularly laterally, and this serves to illustrate the functional areas served by each of the arteries and their territory. Note that in the unshaded area on the lateral aspect of each hemisphere, that's the vascular territory served by a middle cerebral artery. Obviously, the left one on the left side, the right one on the right side, respectively. Note that branches of that middle cerebral artery do not actually reach any point where we reach the margin of a hemisphere, because creeping over the superior and anterior part of a hemisphere, as well as the posterior and inferior part, are branches of either the anterior cerebral artery or the posterior cerebral artery that supply little strips of cortical areas near the margins. But the point is, the boundary point between the different vascular supplies, as illustrated on the slide, constitutes a watershed area, where there's going to be either a sensory or motor deficit that's associated with a sudden drop in arterial blood pressure, probably bilaterally, that affects parts of the motor and the sensory homunculus that are served in that watershed area. The other point we want to make is that on the lateral aspect of each hemisphere, we need to make a distinction between the lateral aspect of the left hemisphere versus the lateral aspect of the right hemisphere. And we make this point by saying that the left hemisphere is considered statistically to be the dominant hemisphere because it contains the language centers. And the language centers are Broca's area and Wernicke's area that you can see are not only in the left hemisphere, they are both localized on the lateral aspect of the left hemisphere in the vascular territory of the left middle cerebral artery. Note that the right middle cerebral artery certainly supplies the same territory, but basically the language centers are always associated with a vascular supply on the left as opposed to the right. Next, let's extend this by looking at the picture on the next slide. And all this does is show us the extent of the territory on the medial aspect of each hemisphere that's served by the anterior cerebral artery, shaded in light gray. As we've already indicated, the anterior cerebral artery is serving the lower part of the motor and the sensory homunculus, because you could see that the medial extensions of the pre and the postcentral gyrus are located here. Again, in the darker shaded area is the vascular territory of a posterior cerebral artery. And as we've seen, its major claim to fame is to provide the blood supply to primary visual cortex that's mainly found on the medial aspect of a corresponding temporal lobe. And we'll see this a little later. Note that the corpus callosum, the massive fiber bundle that interconnects the two hemispheres, also has a dual blood supply. Most of the corpus callosum is supplied by branches of the anterior cerebral artery. But just the back piece of it, the most posterior part known as the splenium of the corpus callosum, is just supplied by branches of a posterior cerebral artery. So when we deal with patients that have what are known as disconnect syndromes, we're going to have vascular insults as part of that conversation to either the bulk of the corpus callosum or the splenium of the corpus callosum and talk about the deficits that are associated with it. Next, let's look at a summary of the different kinds of cerebrovascular causes, infarct causes. And typically they can be thrombolytic, embolytic, or the result of hypotension bilaterally or hypertension unilaterally or bilaterally. Thrombolytic infarcts usually are complications from the development of an atherosclerotic plaque, where there's a progressive narrowing of the lumen of a corresponding blood vessel, usually at branch points of that blood vessel. An embolytic infarct basically can result from a clot being thrown from a plaque, but there are lots of different sources of an embolism. Typically, when emboli are passing through cerebrovascular circulation, most commonly, if they're a carotid embolus, they are most likely to follow the middle cerebral artery and cause a blockage in, depending on the size of the embolus, one of the branches of the middle cerebral artery that's serving the lateral aspect of a corresponding hemisphere. Again, sudden drop bilateral arterial blood pressure might result in a so-called watershed infarct, and when this occurs, it's going to affect the area of the motor and the sensory homunculus in the area of the trunk. So these patients with a watershed cortical infarct are likely to develop what is called the person